So let's start talking about pulmonary embolism, or PE. So pulmonary embolism refers to a blood clot that originates at some other part of the body and travels up to the lungs and gets stuck into the vessels that feed the lungs. Most of these clots will originate in the lower extremities or the legs, but some of them also can come from the arms. So how do you get a clot in the first place? Well, there's something called Virchow's triad. So the first part of Virchow's triad is stasis, and stasis refers to the stagnation of blood or things that are staying still. And so in our lower extremities especially, our blood is reliant on our muscles to push it forward. So the muscles will contract, and as they contract, it pushes inwards on these vessels to propel blood forward and into the inferior vena cava and back into the heart. And so if you can imagine somebody sitting on a plane for a long period of time, not getting up, not moving around or stretching their legs, well, there's not going to be this pressure to push this blood forward. And so let's imagine after that long plane ride, you get up, you go, and you're leaving the airport. Well, now you have this pressure pushing onto the vein. And so as you start having this pressure, well, you're going to have pressure down here, and that's going to help propagate this thrombus upwards. And so what can happen is that this thrombus, which is basically a blood clot, is going to embolize into the pulmonary vessels. And so this thrombus, which was in the legs, is going to be able to be shot off into towards the heart, and eventually is going to make it into one of the vessels up here in the pulmonary arteries. And just for clarification, a embolus is a thrombus, so a clot that is shot off to a different part of the body. An embolus can actually be a bunch of different things. It can be fat, it can be amniotic fluid. It just refers to something that was in one part of the body and gets thrown off to another part. So let's take a look at the general physiology of how blood is processed in the body. So blood comes from the veins throughout the body, goes in through the right atrium, and is pushed into the right ventricle. From the right ventricle, it gets pushed out into the lungs through the pulmonary arteries. Now, at the level of the lungs, they get reoxygenated. You throw off some CO2, and then you bring that blood back into the left atrium. From the left atrium, you shoot it off to the left ventricle, and from the left ventricle, it goes out through the aorta to the rest of the body. And that's how blood usually cycles. So now let's say that you had this clot somewhere in the body, and it's being pushed up through the veins. Well, it's going to follow that same path where it's going in through the right atrium, right into the right ventricle, and then pushed out to the lungs. All of this, the diameter of all of those are pretty big, so that clot's not going to get stuck anywhere. But as it travels into the lungs, the diameter of these vessels get smaller and smaller. And so at some point, it's going to get stuck. Now, if it gets stuck here in the big vessels, we have a big problem. You're not pushing any blood past that. But if it gets pushed into the smaller vessels, then you can divert blood to different parts of the body, but you would still have the symptoms of pulmonary embolism. So with a pulmonary embolism, you travel all this way to get stuck in the lungs, and you stop the forward flow. And if it is big enough, well, you've completely divided this pump, and you are now having pump failure because you're not able to push any fluid forward past the lungs. And so nothing is coming back here, and so nothing is going through the left side and through the rest of your body. So the left heart is starved of blood, which means the rest of your body is now starved of blood. With massive pulmonary embolisms that completely occlude the pulmonary arteries, you can have really quick death. A lot of times patients feel some chest pain, they'll feel dizzy, and they'll suddenly drop, and then they can die. Now, before we move on, I just wanted to finish off the Virchow's triad. So the other two causes that can increase your risk of forming a clot is hypercoagulability, which refers to increased risk of clotting, and endothelial injury. So with hypercoagulability, there's a lot of different things that can increase your tendency to form a clot. But the more common ones that we see is somebody that had a recent surgery or trauma or something like cancer. Now, endothelial injury we had touched on in a previous video, but what happens is that when you have injury to the lining of the vessel, you expose these factors out here that platelets like to attach to. And once they're exposed and platelets are attached, well, you start to form a clot. because the platelets want to close off this injury so that you're not bleeding out into places that you're not supposed to be bleeding in. And so eventually you'll tie this off with your platelets, and your body will recreate the scaffolding and close up the hole. Well, if you have injury like that, you're gonna want to clot that off as soon as possible so you don't bleed. And so anytime you have a surgery, anytime you have really any type of injury to the endothelium, you're gonna have an increased propensity to clot. So what are some signs and symptoms of a pulmonary embolism? Well, the four that we usually see is pleuritic chest pain. Patients are tachycardic, tachypnic, and they can be hypoxemic. So we'll go through all of those. So around the lung, you have a lining just like you have around the heart called the pleura. So in the heart, it's the pericardium. Around the lungs, it's called the pleura. The pleura also help lubricate the lungs as they're moving across the chest wall. And so pleuritic chest pain refers to pain because of irritation and inflammation of this pleura. And so what usually happens in a pulmonary embolism is when you send this thrombus out and it gets stuck into the pulmonary arteries, well, now this entire wedge is not getting any oxygen because there's no blood flowing into this area. And so that area will eventually die. So all of this is gone. Whenever cells die, it causes inflammation. You release inflammatory factors, and your own immune system comes in and tries to clean up the debris. And so this part of the lung is now really inflamed because of the death of that lung tissue. And so when patients are taking deep breaths, when they're taking in deep breaths or when they're coughing, it's going to hurt because that lining is really inflamed. So you'll also have some tachycardia, and the way that I think of the tachycardia is that your heart is trying to push past that clot right here, and so it's going to pump faster and harder and try to push blood through. You'll also have tachypnea, and the way that I think about that is that you have this area of lung that is no longer able to process your blood. You're no longer able to put oxygen back into your blood. And so your body senses that as having a mismatch between the amount of blood that is coming in and the amount of oxygen that's able to be transferred into it. And so your body's going to try to breathe faster to be able to get more of that oxygen inside, because this is limiting the amount that you can push in and the amount that you can actually oxygenate your blood. And so the tachypnea is a way to overcome that. Now, hypoxemia falls in the same line. You have a part of your lung that is basically infarcted, or it's basically dying because there's no blood going to it. And so what happens is your lung is still sending some air into that area, so you're still trying to oxygenate through that area, but there's no blood flowing there. And so when the oxygen is flowing through, well, it doesn't get exchanged for anything because there is no place for it to actually be transported back into your heart. And so because of that, you're wasting air that's coming in that's supposed to improve your oxygen levels. And the term for that is a VQ mismatch. And there's a little bit more subtleties to that whole process, but that's a general overview. Now, aside from these four symptoms, you can also have a little bit of a cough. And if the actual lung tissue becomes infarcted, meaning it dies, you can also have hemoptysis. And in the elderly, you can have atypical presentations, and one that I've seen before is altered mental status. So they come in confused, different from their baseline, and it's very hard to distinguish what it is that's going on with them. Usually my first guess is an infection, but in this case, that patient had recently traveled and had a little bit of leg swelling, and they were acutely altered because of their pulmonary embolism. Now, how will your vitals look? The heart rate is the one that I've seen pretty consistently be elevated, and so most of the patients I see that come in with the pulmonary embolism will have an elevated heart rate, so they'll be tachycardic. Usually they'll also have a little bit of tachypnea, so they'll be breathing above the normal 20 breaths per minute, or the upper limit of normal. And then the O2 saturation, sometimes for smaller pulmonary embolisms, it's not really affected, but for larger ones, you will definitely see a decrease from the baseline. The physical exam for somebody with a PE is pretty normal. You'll have some tachycardia. You'll be breathing a bit fast, tachypnea. If you have a full-on infarction of the lung tissue itself, you can have some tenderness in the chest wall, but in general, it's a pretty normal exam. The one thing that you should look out for, though, is unilateral lower extremity swelling, and that's because if there is a clot there, you should see some swelling there, and sometimes you can have a little bit of redness and tenderness in the calf. So the diagnosis of a pulmonary embolism can actually be pretty difficult because it's not straightforward which test you should order. It's all centered around your pretest probability. And so what is a pretest probability? Well, it is the likelihood that this patient has that ongoing process. So for instance, in this case, it's going to be how likely is it that this patient has a pulmonary embolism before we do any tests? And so if you have a lot of these signs and symptoms, well, your pretest probability is probably really high. But if, let's say you just have a little bit of tachycardia and you have some pleuritic chest pain, well, that can be a lot of different things, and it's not necessarily a pulmonary embolism. And so using that your pretest probability, you have to decide, should I get a lab test for this patient, or should I just go straight to the CT pulmonary angiogram? And so there's a whole set of criteria that you use to determine this. So there are actually a few different set of rules that you can use to determine how you work up a possible pulmonary embolism, but the one that I've used the most is the Wells criteria. So looking at the Wells criteria, you have to answer all of these questions. So let's go through them. So 1, are there any signs of DVT? Which makes sense, because if there's signs of DVT, well, that venous thrombosis from the leg or the arm could actually go into the heart and back into the lungs, causing pulmonary embolism. So the next one is the pulmonary embolism, the number 1 diagnosis, or equally likely, so that makes sense. Heart rate greater than 100, so that's tachycardia. Immobilization or recent surgery, like we said before, when blood is stagnant, when you're not moving a lot, you tend to clot, so that makes sense as well. If they've ever had a PE or DVT, so if you've ever had it before, you're going to be a little bit more likely to get it again. Hemoptysis, like we talked about before, with the infarction of the lung, if that lung dies, you're going to start coughing up some blood. And then malignancy or with recent treatment. So just like we had mentioned before, whenever somebody has cancer, it increases the how likely they are to form clots. And so each of these are assigned a point value, and then you add up all those points, and depending on how many points you get, the criteria tells you whether you should order the lab, the D-dimer, or you should order imaging like the CT pulmonary angiogram. And so in my last video on labs, I talked a little bit about the D-dimer, so go ahead and watch that. But we'll talk a little bit more about the CTA pulm here. So what's a CT pulmonary angiogram? Well, it's a CT, but you use contrast that you put inside the veins so that you can have a better look at what the veins and arteries look like. And so if this is your heart and these are the pulmonary arteries leaving the heart going to the lungs, you put contrast into the patient. And so this contrast will start to fill these vessels, and they'll fill up in the pulmonary artery as it goes to the lungs. Now, if you have a clot, let's say you have a clot right here. So here's your clot. There's nothing going past that. Well, the CTA pulm will show contrast going all through here, and all through here, but nothing will go here. And so you'll see contrast. You'll see contrast all throughout these vessels here, and here, but it stops right here. And so when you look at the actual CT scan, you'll see no contrast here, and you see it everywhere else. And so you'll see that there is a clot in this area. And so with that, you're able to diagnose a pulmonary embolism. So how do you treat a pulmonary embolism? Well, it all centers around anticoagulation. So if coagulation means you form clots, anticoagulation is breaking down clots. And so what we do is we give medications that don't necessarily break down the clot, but it prevents you from building up more clot. And so your body has its own way of breaking down the clots that are already formed. So if you and you're always in a balance between making clots and breaking down clots. And so if you stop the making clot portion of that system, well, now you're just breaking down clots. And so that's how we generally anticoagulate people. The only caveat, though, is if you have a gigantic clot, and you're basically occluding the entire pulmonary artery so that blood can no longer flow this way, and you're all stuck right there. Well, that is not compatible with life, and so you need to get rid of this clot ASAP. And so what we do is we push something called TPA, which is an actual clot buster. And so if we push TPA, it's going to break up this clot, and you'll be able to push through and go back in and push blood into the lungs. The only thing with TPA, though, is if you're breaking up clots here, well, you're going to be breaking up clots everywhere else. So if you had any recent surgery, you're going to start bleeding through those cuts they had done for surgery. Or if you had a recent hemorrhagic stroke or something like that, where you bled into your brain, well, you're just going to open up open up that area to bleed again. And so you always have to balance the risks and benefits of using something like TPA. So we don't use it for everybody. We only use it for patients that have those gigantic clots. So if you have a smaller clot like this, in the hospital, we typically start something like a heparin drip. And so heparin is one of the anticoagulants that you can use to help break down some of these clots. Now, there are a bunch of other anticoagulants you can use. There are new oral anticoagulants that you can use after a patient's discharge. And so that's a whole treatment algorithm that you probably don't need to know about at this point. But just a basic summary of a pulmonary embolism. So pulmonary embolism is a clot that goes to the lungs, and it's from another part of the body, most likely from the lower extremities. So if you see somebody that you're suspicious for pulmonary embolism, make sure you look at the legs as well. And so the signs and symptoms of pulmonary embolism, the one that I've seen most consistently is tachycardia. They'll also be breathing a bit fast, and their oxygen saturation can be low. The other symptoms you can get is that pleuritic chest pain, the pain that you have when you take a deep breath in, and their oxygen saturation, again, like I said, would be low. To determine what you want to do for the pulmonary embolism in order to test it, look at the Wells criteria, and then the treatment is anticoagulation. So next we have a pneumothorax, and a pneumothorax is basically when air from inside the chest wall leaks outside of the lungs, and it fills up the space between the chest wall and the lung itself, causing collapse of the lung tissue. So in a normal system, you usually don't have any space between the chest wall and the lungs. So there's really no space between here. Usually it's just your pleura between the two. Now with a pneumothorax, all this yellow right here is air. And so this lung collapses inwards because there's air outside, and you can no longer inflate the lungs, because the lungs work through vacuums. And so if there is space between here, the lung is no longer able to create that vacuum to actually suck air into it and expand. And so you have this space here full of air, the lung collapses inwards, and then you start to not be able to oxygenate very well. You can't get oxygen to your blood because this lung is no longer working. So if you do have a pneumothorax, however, you don't have to have complete collapse of the lung. It could just be a certain portion of the lung, and the rest of the lung would be filling this space here, but then you have this area right here that is collapsed in. So it doesn't have to be the full lung. Now, what are the common causes of pneumothorax? In all honesty, trauma is the one that I've seen the most. But then you can also have people have spontaneous pneumothoraces, but those aren't usually this giant collapse. It's usually just a portion. So with a pneumothorax, the symptoms that you have depends really on how big the pneumo is. But typically you'll have some pleuritic chest pain, and you'll be short of breath. For your vitals, you'll have an elevated heart rate, elevated respiratory rate, and you can also have a decreased oxygen saturation, but it really depends on how big the pneumothorax is. And so on exam, the key is having absent or decreased lung sounds. So because the lung is so far away from the chest wall, the lung sound are very faint, or sometimes you can't even hear them at all. The other thing is that if you tap on the chest wall, you will hear a more hollow sound instead of a more dull sound. And so that hollowness is because of the air that's trapped between the lung and the chest wall. Now, how do you diagnose and treat a pneumothorax? Well, the diagnosis is with the chest x-ray, and I will go over what the chest x-ray looks like during our imaging lecture. But generally, you'll see blood vessels kind of coming out to the edge on the normal side, and the vessels you'll see all the way to the actual chest wall. But on the other side, you'll see those vessels go up to the lung, and you'll see all of this space free of any vascular markings. Now, what do we do for them? Well, if they're small, we typically just observe and we repeat chest x-rays to make sure that they're getting better. A lot of these will just resolve on their own. If you have a traumatic injury, you would generally insert a chest tube. If it's really large, you can insert a catheter and try to reinflate that lung. But if you have a tension pneumothorax, you need to immediately decompress with a needle. A tension pneumothorax is when you have air accumulating within this space and it's under pressure. And usually that will happen because there is a one-way valve that was made. And so typically this is with some type of trauma. So if you have a opening right here and you allow for air to come in, but no air can come out, you start compressing that lung and compressing that side of the chest. So because of this one-way valve, you start to increase pressure within this side of the chest. So on the left side, pressure starts to build up and starts to push all of the chest contents to the opposite side. And so your trachea will move to the right, the heart will also move to the right, the vessels coming out of the heart, supplying the lungs and supplying the rest of the body, also move to the other side. And so as everything gets smushed onto that side, all the vessels and everything become compressed, and you can lose the ability to actually perfuse outside of the chest wall because the pressure is so high. And so this entire system inside the chest can fail. So that's why it's so important to, instead of having that one-way valve, you need to create another opening here to allow pressure to be released. And lastly, we have pneumonia. So pneumonia doesn't really typically fit in what we've been talking here so far, but it does cause chest pain, so we will talk about it. So with a pneumonia, basically a pneumonia is a lung infection. So just like you can get a cold and have a upper respiratory infection, meaning an infection of your throat, your nose, your ears, that process can travel down into your lungs and cause an infection there as well. So you typically will see a patient with shortness of breath. They can also have fever, though the fever isn't consistent in patients that are elderly. I've seen plenty of elderly patients with looking really good and having pneumonia. They can have a cough, and it can be productive or non-productive, meaning you're producing sputum or not. And the chest pain they have is typically pleuritic because you also have that inflammation of the pleural lining. And so if you have an infection here, well, that infection can irritate that pleura and cause pain when you take a deep breath in or when you cough. Now, on physical exams and vitals, you would maybe see your heart rate up, you would maybe see your respiratory rate up. Sometimes you can have a fever, and sometimes your oxygen saturation can be low. And I say sometimes because it really depends on how severe the pneumonia is. If it's a severe pneumonia and you have something like sepsis, well, your heart rate's going to be up, your respiratory rate's going to be up, you're going to have a fever, and your O2 sac will be low. But if it's just a walking pneumonia or a community-acquired pneumonia that's just starting, you might not have any of these signs or symptoms at all. If you listen to the lungs, you can sometimes have crackles, which is kind of like a Rice Krispie type sound when you pour milk over it. And that's because of the fluid that's inside the alveoli, and that's the sound that they make when they try to reinflate. You can also have rhonchi, which is, the way that I think of it, it's kind of like that snoring sound that you get sometimes when you have like an obstructive piece of gunk in your airways. Agophony is a really interesting exam finding. Basically what it is you listen to the lungs and you ask the patient to say the letter E. And so they'll say E, 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 but when you're listening to it on the chest, it'll sound like A, so it's called the E to A sound. So they say E, 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 and for you, it sounds like A. And aside from that, you can also tap on the chest, and if you think about what a pneumonia is, it's basically a consolidation of pus and bacterial infection in a certain area of the lung. And so if you're tapping along the chest wall over here, it's going to sound pretty airy. It's going to sound like there's air in there. So it's not very dull. But once you hit this portion where the infection is, it's going to sound dull because the lung is more consolidated. There's not as much air in there. And so you typically diagnose a pneumonia with a chest x-ray, and you will see kind of a consolidation in the lung. It'll look more white and dense. And we'll go over it when we go through radiology. The other thing you can do is get an ultrasound. And a lot of doctors now that have the portable ultrasounds will be able to use that at bedside and see almost immediately whether or not the patient has a pneumonia. And so that actually saves the patient time, saves them the need to go to radiology and get that chest x-ray and wait for somebody else to read it. And then the treatment is antibiotics. And it really depends on what type of pneumonia they think they have. And so the antibiotic choice is going to depend on the risk factors and where they got the pneumonia. And so I hope this section made sense and it wasn't too overwhelming. But I hope you guys are seeing why it can sometimes be difficult to narrow down a differential diagnosis, because a lot of these symptoms can sound the same. But what I would want you to do when you're thinking about these cases is think about the different organs in the area and think of what the signs and symptoms would be if they had something like a myocardial infarction versus a pneumothorax, and start comparing what each of those illnesses would look like. And that process of being able to recognize those patterns is very important, because that's really what being a doctor is it's recognizing the pattern of illness that the patient comes in with and being able to fit that into something that is more likely. And in the end, I want you to be able to develop that thinking style and that process of elimination, so to say, as you're going through cases, so that by the time you're done reading through a case or seeing a patient, you would be able to eliminate most of your differential diagnosis and fixate on just one. In the last set of videos in this series, we're going to talk about the common causes of chest pain that originate from the abdomen. We'll also talk about some of the musculoskeletal causes of chest pain, and then we'll talk about anxiety as well. If you have any feedback for me, I would really appreciate it. And if you want to keep supporting this effort, subscribe to the channel and like the video, and let me know how we can improve this system.